out there that as you start writing care plans and really preparing yourself for the clinical side of anesthesia, that can be kind of helpful for you. So I'm going to share those with you guys, and please don't feel like you have to run out and purchase these. And there's a variety of options out there when you look at stuff. So the first one, and one you've probably heard of before, is called Vargo anesthesia. And they all have like advantages and disadvantages to them. This is Vargo. It's an app. You can get it for App Store or Google Play, any of those sorts of things. So the good news about Vargo is it's CRNA driven. It's fairly up to date. The downside is it's kind of a limited perspective. So when you look at this stuff, you may realize that even though you've got a lot of helpful information, it may only be one way to do the case. So this is something for you to look at here. But like I said, you may see that when you go to your clinical site that the way they talk about doing a case in here is not the way they do it at your facility. But it's a good starting point or a reference for you. Manoj just said that Vargo is on sale in November. And Brooke said she thought it was about $80. So that's one option for you. A second option is to, look at one of these kind of old-fashioned things we call books that have some good resources for you as well. I think the go-to is Jaffe, the Anesthesiologist Manual of Surgical Procedures, and it really takes you in great detail through everything you'll see in there. And you don't have to buy it new. I mean, there's probably more up-to-date information in the newest version, but you could probably pick up a used version of things somewhere without any sort of issue. So that's something I would look at as well. And then kind of the older version, and this one looks really grainy, is Samuel's Anesthesiologist Manual of Surgical Procedures. Again, just another option for you. So cheap things, especially if you pick it up used, but the actual books probably provide you with more information than the app does. Something else to think about, I sent it out to you guys, but if you're interested, BlockBuddy has a discount running right now for everybody to look at. It's good for a year. So if you're not sure that you're going to use it, you can wait and purchase it. I think it was like 50% off, like I said. So that may be something helpful for you there to kind of pick up. Other things, and what I did, and it will vary for each of you as you go from one clinical site to another, is I saved all my care plans. I don't want to say it's like gaming the system, but some places you can type out your care plans. Other places you have to do them by hand, probably because of people like me that, saved them and used them again. But, when you do a lap chole is a lap chole. There may be little variations to it, but it's fairly standard. So it's not really a good use of your time to have to do a whole nother care plan. So I kept an electronic copy of all my care plans so I could go through and just edit them the night before. And then additionally, I had a folder I carried around in my backpack I took to clinicals that had all those care plans with me. So if I needed them for any reason, I had it there and available for me. So that may be something you think about doing as well. But you'll figure out when you get to your clinical site really how care plans work, and kind of the flow of those sorts of things. Other resources, and I'm sure you guys have a lot of the same stuff out there, just kind of a pass down book, or like, any sort of pass down information from one class to another. I know you guys have some online resources. I'm going to call out Andy because one of the girls I went to school with stumbled across one of his online reviews and she thought it was hysterical. So, stuff like that will be helpful for you guys. And when you write these care plans and you prepare stuff, share it with each other. You guys are all kind of in this together. You don't have to reinvent the wheel for a lot of this stuff. So that's definitely something I would consider doing. Do you guys have any questions about care plans or any of that sort of stuff? As far as like, what you need to prepare, what you need to think about, those sorts of things? Awesome. That makes life easier if you guys already have all that information and know everything. I'm kidding. Like I said, you will figure out a lot of that when you get to clinicals and start actually doing things. The other thing, if I can get it to work, is I'll try and post the folder I have my care plans with on here for you guys to download. Some of them are obviously a little dated because I haven't written any care plans in like 15 years, but it may be something helpful for you guys to kind of use as a jumping off point for things. Things will need to be updated because, there's, medications have changed and that sort of thing. I agree, Josh. You guys don't even know what you need to ask yet. But certainly when you guys get to clinicals, please feel free to call, text, email. Not like all 100 of you every day. But if there's things you're really struggling with, I don't mind answering questions at all. Brooke's question is there a specific template we need to follow for the care plan? It varies from one clinical site to another. I was trying to find an example of some of the ones from JPS for you guys to see. But most of the time, each clinical site has their own kind of standardized form that they want you guys to use. So I can't give you an across the board answer for everything, because everybody really is a little bit different as far as what they want or don't want, and that sort of thing. But like I said, I'll share those for you guys to look at. And if anybody has any questions, you're always more than welcome to ask. I don't mind sharing it all. All right, so hopefully everybody took a little time to work at learning those medications, kind of getting your brain back into that Pharm mode, because it is stuff that you're going to need to have pretty quickly recalled. Couple questions that came up. The first one was regarding morphine dosing. So what you'll see as far as variation is that sometimes the dose of a medication you give intraoperatively may be very different than what you give postoperatively. Part of the reason for that is that when you're intraoperative, you're worried about your patient waking up, them breathing okay on the back end. Say, for instance, you give somebody a whole lot of morphine, they may not want to breathe on the back end because you've essentially overdosed them. During the case, it's fine because they've got the ventilator breathing for them. But on the back end, they may not want to breathe after you're trying to get them extubated. So that can be problematic for you. When you get to recovery, you kind of trade one thing for another because they're breathing on their own. So you can kind of titrate pain medication to their level of pain as opposed to just like hemodynamic response. But you also no longer have that ventilator safety mode. So if you give them too much medication, then obviously they wind up respiratory depressed, and that can be problematic for you as well. So you may see that the intraoperative dosing and the postoperative dosing are a little bit different for that reason. The other thing is when we provide you with like medication doses, it's across the board. So we can't tell you that this is the dose for every situation. I'll give you, and since we're talking about morphine, we talked about 1 to 10 milligrams being given as an intraop dose, and then 5 to 20 milligrams postoperatively. You have to remember when your patients are under anesthesia, they are also getting other things that may affect their analgesic kind of level. Giving somebody a volatile anesthetic that's also a little bit of a muscle relaxant may provide a little bit of a synergistic effect for your opioids and stuff like that. Generally, when they get to the recovery room, they're only going to be getting, IV opioids or maybe a little bit of ketamine or something like that. They're not getting kind of the multimodal approach we utilize in the operating room to cover patients for pain. So that's something to think about. And then, like I said, the patient, driving, I'm in pain, I have a pain level of 10 out of 10. Those things make it a little bit easier to kind of gauge where your patient is in their kind of quest to be pain-free or reduced pain. All right, so I'm going to run through the PowerPoint that we put together. If you guys have any questions as we go through this, like I said, most of this should be a review for you. But if you do have questions, please let me know as we move through it.
Hey, Dr. Cornelius, can I ask you a labor analgesia question?
Sure.
So for the epidurals, it has the like doses listed as a percentage. And so I'm reading like a concentration. So then the dose or the mLs that we give, is that just based on like how many like vertebrae we want to cover?
Yeah, usually it's 1 to 2 mLs per level. But and you're talking about strictly just for opioid stuff, correct? I mean,
No, for
for
the
opioids, for epidurals. Sorry, brain fart. You're talking
yeah,
about just for epidurals, right?
right.
So let me pull up the reference so you guys can see what we're talking about here. So when you look at labor epidurals, the most common concentration of medication that's administered as part of a labor epidural is ropivacaine, 0.2%. Some places you go, they will add fentanyl to that. If they add fentanyl to it, usually it's going to be 1 to 2 micrograms per ml. So then there's not a magic. When you set up somebody with an epidural, you go through, you put your epidural in. Usually you give a bolus when you initially place that epidural. That bolus may be off the pump, or you may hand push it. We also will generally give the little bit of lidocaine with epinephrine that's left over after our test dose, and then give the bolus. Like I said, there's not a magic formula as far as how much you give of a bolus. The dosage is usually either a half or a 2:1 of what you want your hourly infusion to be, but that's just kind of a loose rule of thumb. There's no definite amount. So, like I said, 0.2% ropivacaine is the most common. And generally what we will do is 1 to 2 mLs for each level we want to cover. So most of our patients will wind up with somewhere between 10 and 20 mLs of ropivacaine infusing per hour of that 0.2% concentration. Like I said, sometimes it has fentanyl in it, sometimes it doesn't. There are places that will use Marcaine, but bupivacaine, just because of its safety profile, is a little bit more common for use. Did that answer your question?
Yes, thank you. And then just to decide like your hourly rate, is that like if you were to use lidocaine, would you do like more per hour since it's like a shorter acting as compared to Marcaine? Like how do you decide on your hourly rate?
Usually it's, like I said, going to be based off of the amount of levels you're trying to cover and the patient's height. Smaller patients, you usually reduce it by a pretty significant percentage. I've never used lidocaine as an epidural infusion. Probably just because we always have either Marcaine or ropivacaine available. You may wind up in some sort of weird situation where all you have is lidocaine to go in your epidural, but just because of the short duration of action, I don't think you would get very good coverage from it. I don't know if that really answered the question, but it's just
No,
not a common behavior here in the US to do that. But there could be times that, like I said, you're on a mission trip somewhere and all you have is lidocaine for your epidural or something like that. Like I said the other day, there are a lot of times I will combine like lidocaine and ropivacaine or lidocaine and bupivacaine to get a faster onset and a longer duration of action. But just using lidocaine, probably not going to happen terribly much. So kind of the standard dosing when you're looking at those concentrations and those medications. For an epidural, if you are using bupivacaine, usually it's, like I said, 10 to 20 mLs. And I know what it says here as far as the 0.625 or 0.0625, but I think the more common dosage you guys are going to encounter is actually going to be a little bit higher. Usually it's 0.25% to 0.5% infusing in that epidural. 0.25% probably being the most common. So it's kind of handy because if you're remembering like the dosages, usually the ropivacaine is 0.2% and the bupi is usually like 0.25. So fairly similar there. And the other thing you have to think about, in part of the reason we go back and check our patients after we start those epidurals, is making sure we're achieving a high enough level. So usually, like if we're using an epidural for a C-section, we'll give at least a 20 ml bolus. Now it may be divided up into like 5 mLs at a time. Say for instance, when you look at medications that we bolus through an epidural for a C-section, lidocaine with epi is common for that because we're not looking for long-term labor analgesia. We're just looking for short-term coverage during that procedure. So probably the most common medication used as an analgesic through an epidural for that C-section is going to be lidocaine 2% with epinephrine, because it does give you a little bit longer action. And usually the way we do that is bolus 5 mLs at a time, up to like 20 to 30, depending on the patient's weight and kind of what's going on. But as you're bolusing that, and part of it comes with time and experience, you know, about based off of this patient size, I need to administer this much. Most patients getting 10 to 20 mLs, but sometimes they need a little bit more. Sometimes you give a totally appropriate dose and they don't get relief. But 5 mLs at a time, up to like 20 or 30 mLs for those patients. Does that make sense?
Yes, thank you.
Okay. So things I would make sure when you start looking at your locals, kind of the popular questions, like I said the other day, dosage, being able to figure out your concentration based off a percentage as opposed to just knowing how many milligrams per ml, and then knowing what your max dose is. There's another app out there. I'll see if I can bring it up here with the list of apps I had. That's kind of helpful when you start looking at local anesthetics, because as you start doing some of this stuff yourself, it's a little bit hard to remember, but it's called Safe Local. The nice thing about using Safe Local is that it allows you to go through and combine multiple medications. So like if I'm administering bupivacaine and lidocaine together, it will add both those in there. You can also go through and add some of your patient comorbidities, not that they usually come into play in the lower doses that we're administering, but like patients with renal failure, vascular disease, stuff like that. It's a free app from Johns Hopkins, so it may be helpful for you to add that onto your iPhone if you got one. But that's another helpful one for you. Other apps that are helpful while we're talking about other stuff, we talked about Block Buddy. That's generally a helpful one. The Nysora app, if you don't get Block Buddy, is kind of helpful. Those are the big ones that I would look at as far as helpful, other than, like we talked about, Vargo is kind of a helpful app to pick up, just because it's got a lot of different stuff in it. But those are the big ones I'd look at. Another one that's kind of helpful it's like Vargo, but probably not as good, is called Master Anesthesia.
Dr. Cornelius, I think you're muted.
Oh, thank you. Where did I cut off there? Sorry, I don't know why it muted.
Master Anesthesia.
Okay, so this is the Master Anesthesia app. Again, available for all those platforms. It's similar to Vargo, but I think it offers a different perspective on some stuff, and some calculators in there. So I think that's kind of a helpful one when you start looking at stuff there. As far as like the procedures that are available, it's got a lot of different cases in here. And again, so it's kind of a different perspective. The other nice thing for you guys, when you're writing your care plans, when you look at Master Anesthesia as opposed to Vargo, is the online version, or the like computer-based version of Master Anesthesia, is pretty easy to copy and paste into your care plans. And it's pretty straight from Jaffe. So that may be an option for you as opposed to going out and buying another book. But as you can see, this is kind of what a normal care plan looks like for these things. The one thing that I don't like so much about Master Anesthesia is it covers a whole lot of the case stuff, but it doesn't necessarily get into the medications. Teams is killing me today. I'm not sure why. All right, now you guys can see it. So it's got a ton of cases here, but like I said, it doesn't have the medications in there. It has general stuff like, okay to use paralytic, may not use paralytic. But it does go through and discuss a lot of considerations for things. And the nice thing, like I said, is you can go through and cut and paste this into your care plan. So that saves you a little bit of time, because when you're trying to sleep and do care plans and stuff, every little bit counts. So that's what they have as far as like the cases. They also have a decent amount of medication information here. It's just not integrated, so that makes your life a little bit different or more difficult there. But same thing here, dosage, indications, contraindications, all those things for the different medications. It also provides you with the references there. So that's kind of helpful, because some places do want you to have references for your care plan. Like I said, when we were talking about the different medication reference sheets, you may see there's some variation between max doses for one thing and max doses for another. Another helpful thing is they've got a lot of different medical problems in here. So if you're looking at a condition, this may be helpful for you for anesthesia specific considerations. But for especially like some of the pediatric stuff, you may figure out that Dr. Google is your best reference for weird syndromes and stuff like that. These are the calculation options that it provides for you as well. So you can put in patient's weight and then figure out all sorts of things, NPO time, fluid losses. If it would work. There we go. So it'll provide you with kind of your table for calculating things. It provides your kind of respiratory specific stuff, talks a little bit about your patient's body habitus. So that's kind of a helpful one for you. And then it will also provide you a little bit of explanation for those things, as well as the formulas. So just another tool to put in your toolbox there. Any questions about that? Yeah, Samantha, I was saying ropivacaine and bupivacaine are your two most common locals that you're going to wind up using outside of lidocaine. All right, we'll hop back over to the presentation. All right, so this is, like I said, it's just kind of a common review of stuff. We can't go over all the medications that you guys have talked about over the program. So we're going to go over a whole bunch of different stuff. But like I said, it's not a complete review. It's just kind of the common medications. You're more than welcome to keep this as a reference for things. And like I said, if you get to clinicals or you're writing a care plan and you're just stumped, please feel free to send me an email, stuff like that. I don't mind at all. So one of the things that is kind of confusing to people when they get to clinicals is figuring out MAC, because MAC can mean a whole lot of different things depending on what you're talking about. MAC can mean monosteroid anesthesia care. It can mean minimum alveolar concentration. But one of the big things you have to remember for that MAC is that the MAC value is where 50% of patients will not show a motor response to incision. So you think about that, there's a significant number of patients that will be too much anesthesia, and a significant number of patients that will not be enough anesthesia. The other thing that comes into play is figuring out all the other medications that you've given to this patient, analgesics, sedatives, hypnotic drugs, and how they've impacted things. So when you're looking at the MAC for just your gas, that's all it's taking into account. So most of our patients will still be appropriate with that MAC value, even though we know we're underdosing about half our patients and too much for part of our patients there as well. One of the things I say a lot of times is to let your patient drive your anesthetic. So we're giving them a whole lot of medications to make sure they don't remember what's going on. They don't have difficulties. They are not experiencing a whole lot of sympathetic swings because of surgical stimulation. So you may see that all those things come into play and the patient doesn't have awareness even though you're running them at what you may not feel like is an adequate dose of just your volatile anesthetic. So that's just kind of a general overview for you. Let the patient show you what they need. Are you seeing lots of hypertension, tachycardia? That may be a sign that the patient's experiencing significant stimulation, even though you're providing them with what you think is an appropriate anesthetic. On the other hand, you may be providing what you think is an appropriate anesthetic and your patient's blood pressure is extremely low. You haven't seen a bump in their heart rate at all. So you may be giving them too much, and that may be, I say a lot of times you're creating your own problems, but you are, because you're giving the patient too much anesthesia. And as a result of that, you're seeing that your blood pressure is low, they're bradycardic, and you're having to give medications to kind of counteract the effects that you've caused. So a lot of anesthetic gases out there. We're going to talk about some of the specific nuances, but we can't get into all the details. I would make sure you're pretty familiar with this chart. You will probably see it, or at least its effects, when you get to clinicals. The most common ones that you're going to wind up talking about or seeing are kind of the airway properties. So for instance, like desflurane smells funny. It's very irritating to the airway. You will see that patients cough pretty extensively when they get desflurane. So if you've got a smoker or somebody with asthma or reactive airway stuff, probably not a good choice for those patients. Like I said, it also smells bad. Not that any of them really smell good. Especially if you use large doses or you titrate it up quickly, you'll see that there's a rapid increase in heart rate. The good news is that it's very poorly soluble, so obese patients tend to get rid of it very quickly. The downside is it's very expensive, and it requires a special heated vaporizer. So if you've run out of plugs on your machine, you may be out of luck if you're trying to use desflurane. SIBO is probably the most commonly used volatile anesthetic out there. The good news is it's not very irritable to the airway, so we can use it for mask inductions or kids or other patients that maybe we don't have an IV in place for some reason. It does cause emergence delirium in kids. Indeed, it's the most common cause of emergence delirium in pediatric patients. Cost-wise, it's not that expensive. It's definitely more expensive than isoflurane, but it's also significantly less expensive than desflurane. If you have very large patients or use it for long periods of time, especially in high concentrations, you'll see that it sticks around quite a while. So there's some variability on what the actual time frame is, but you will see that in longer cases, if you've been running your SIBO at very high doses, it may lose any sort of benefit as far as going away quickly when compared to isoflurane. It's been indicated to cause nephrotoxicity in rats. Hasn't been proven in humans, but there's probably some sort of causation there that does carry over to human models. And like I said, it's probably the most commonly used volatile anesthetic. Isoflurane is not used quite as often, other than kind of strange little geographic things you run into. If you wind up working with me, I use isoflurane for almost every case. It's very cost efficient. And the nice thing is that if you use it appropriately, you'll see that you don't have any of the prolonged wake up, any of the issues that are kind of like the bad things that people think about with isoflurane. The other thing that comes into play is it's very cheap. So when you go to a lot of the public facilities or places that don't have a whole lot of money or are using their money for other means, you may see that they have isoflurane as the agent in every room. On the other hand, like we had one private hospital we went to when I was in school that they used desflurane for everything in the hospital. The only thing they didn't use des for was pediatric cases. So just kind of weird regional variations there. If you go to Shreveport, they use ISO a lot. But like I said, as far as people taking a long time to wake up, but the thing you'll figure out is that ISO provides more relaxation at a lower dosage than SIBO or DES. So a lot of times you can extubate a patient that still has like 2 or 3% ISO on, whereas with SIBO, you have to wait on it to go away. If you have like an ICU patient that's on a ventilator and they're coming to the operating room, or somebody that's going to go back to the ICU on a ventilator, ISO is really your drug of choice because there's no concern about quick wake ups or any of those sorts of things. Another note, and it's, I hate that healthcare is like this, but there are very easy programs on most of our anesthesia machines now that track the amount of volatile that's used. So things that come into play from that perspective is what medication you're using and then your flow rate for it, because that's really the two variables that kind of affect the cost there. The concentration affects it obviously as well, but if I've got gas going at 10 liters per minute, I'm going to use a lot more gas because it's being blown off faster than if I've got it running at like a half or 1 liter. So one of the things you have to kind of keep in the back of your mind is keeping an eye on your flow rate during the case. You're all going to do it at some point. You're going to induce your patient, turn your gas on, and you're going to be like 30 minutes in the case and realize you've still got your oxygen going at like 15 liters a minute. Then you get to refill your vaporizer. But it's just something for you guys to kind of keep in mind as, being financially responsible. Nitrous is something you will also see kind of has regional variations, and it probably has age variations too. I think a lot of younger providers avoid nitrous because they're not comfortable with it or they don't have a lot of experience with it. I use nitrous a fair bit, especially for times that maybe I have a patient in pain, but I also want to make sure that they're going to breathe adequately on the back end. So we use nitrous really as like a complementary anesthetic gas. There are very few times that you'll use nitrous as a solo anesthetic gas. And when I say that, I mean that you're using nitrous with like air or nitrous with like oxygen. For instance, like if you're doing a mass conduction on a pediatric patient, you'll use nitrous and oxygen. There are other times that you may use nitrous as kind of a wake-up tool because it does kind of relax your patient as they wake up. Or if you've had to run your volatile anesthetic at a very high rate during a case, you may turn your volatile off and then use nitrous to allow that gas to blow off, but they're also continuing to get analgesia during the wake-up. So one of the biggest things that you hear is kind of like the bad rap for nitrous is that it'll cause nausea and vomiting. A lot of that has been disproven, but the rep still kind of sticks with it. So you'll run into people that refuse to use nitrous because they're concerned about patients with nausea and vomiting. For the most part, any sort of implication of nausea and vomiting has been tied to extremely high doses. So saying like 70% nitrous. The other thing is kind of a caution for nitrous is to be cautious with anything that's an enclosed space because it will wind up diffusing out. So if you've got a cranie or you've got somebody with like a bowel obstruction or an insufflated abdomen, something like that, you can wind up increasing pressures in those areas using nitrous. So things to think about as far as the factors that are going to increase or decrease your anesthetic requirements. Increasing chronic alcohol use, infants. Remember, I think this is like one of those most common board questions is that the highest MAC is at 6 months. Red hair, hypernatremia, and then hyperthermia. Decreasing anesthetic requirements, acute alcohol intoxication, older patients, hyponatremia, hypothermia, hemoglobin being extremely low, hypercapnia, hypoxia, and pregnancy. So why do we use anesthetic gases? The biggest reason is the speed of onset and the ability to titrate things. Other things that kind of come into play, they're very potent. They do have a very narrow therapeutic window. When you start thinking about something that you're titrating based off of 1%, that's crazy. If we have medications that we were dosing based off of 1%, people would, have a fit. Other things to think about, there's very little metabolism associated with it. So usually gas goes in, gas comes out. Some of the older agents were a little bit more problematic, especially like halothane. But with the newer agents, we don't really have quite that much of a problem. Other things that are kind of problematic for the gases is we don't entirely understand how they work. And we're using basically what the patient breathes in and out as a reference for what they're actually getting as far as sedation to their brain. So it's not a direct measurement of the sedation level, it's just a concentration. So things to think about here, know the differences, know when you would use one gas versus another. Like I said, the big reasons we've already talked about. Other things to think about, a lot of it comes down to provider preference or like facility stuff. You may not have a choice in it. You will see some places that use a lot of DES. It's almost a fight in the morning to find a DES vaporizer. So when you think about it from a logistical standpoint, now that's one more thing you've got to go find in the morning, and then bring it to your room. You may go someplace that they've got, all 3 vaporizers in every room. But it's definitely a consideration for you. So, and then, like I said, for pediatric patients, by far the most common agent used is going to be SIVO. All right, so we're going to transit. Any questions about gases? I know it's kind of a quick review of things. All right, we're going to transition from that to the IV induction agents. Propofol is by far the most common medication that we use for induction. We also use it a lot of times for sedation, and then we'll use it as our primary agent for total IV anesthetics. Big advantages of it, patients are awake very quickly and they've got a lot less nausea and vomiting. Remember that propofol is actually an antiemetic agent, so that's definitely a consideration for you. The standard concentration is 10 milligrams per ml, and the most common supply is going to be a 20 ml, so 200 milligram vial. If you think back to your ICU days, they also have a 50 ml or 500 milligram vial, and then a 100 ml or 1,000 milligram vial. Most commonly, if you're using the bigger vials, it's probably going to be for like an endo case or as part of a TIVA anesthetic. Dosage-wise, kind of the jumping off point for patients is 2 milligrams per kilogram. For sedation, it's usually like 25 to 100 mics per kilo per minute. And then for TIVA, dose is a lot higher. And part of that, when you start looking at the TIVA dose, depends on what other medications you're using and then the age of your patient. So just kind of a reference point for you. What we call sedation is not what you think of in terms of like operating room sedation. Sedation here is more of like what you saw in the ICU. We will do like, say, a colonoscopy, for instance, and we're using propofol as our maintenance anesthetic. Those patients are going to be getting a lot higher dosage. It's more in like the TIVA or general anesthetic range than really like a sedation range. And you'll see, especially in pediatric patients, that you may quickly approach like that 250 to 350 mics or 300 mics per kilo per minute. Propofol is not a controlled substance, but a lot of places still treat it as such just because of the high abuse potential. So you may still be responsible for wasting it. They may track your administration, stuff like that. So be familiar with the regional practices wherever you go. Other things to think about with your propofol, it's painful if you push it. So there's a couple ways you can kind of get around that or help it out. Pre-treating your patient with 1 to 2% lidocaine works well. Other things you can do, instead of just slamming it in there because it is painful, push a cc or 2, give it 30 seconds to kind of desensitize the vein, and then follow. Or you can just push it slowly. I'm not sure when this changed, but for probably the last 2 or 3 years, everybody is like in a race to get that propofol in there as fast as they can. You know it's uncomfortable, you know it burns. Don't try and slam it in those patients. Giving any medication in an IV feels weird. Even if it doesn't actually hurt, it kind of causes a weird sensation in patients. So just be cautious with that. Things to think about, you don't really have to change your dosing with renal or liver disease, but if you have especially like poor cardiac patients, you're probably going to want to either use a different agent or decrease your dose rather significantly. One of the nice things about that is that propofol is very titratable. So when you're inducing those patients, if you don't get in a rush, you can give a little bit, ventilate your patient, and give a little bit more. You don't necessarily have to slam it into everybody and then move on with life. You can kind of work through it. Nice thing, patient's unconscious very quickly, usually within 30 seconds, if not less. Downside or upside, depending on how you look at it, the half-life is 30 minutes to an hour and a half. So if I'm using it just as an induction agent, it's not really a big deal. But say I'm using it as part of a TIVA, think about how far ahead you're going to have to turn that medication off to have your patient wake up. So a lot of times for like neuro cases, whether they be back snacks or cranies, we'll do TIVA. You're probably going to have to turn the medication off 30 minutes to an hour before you think they're going to be done. And you haven't figured it out yet, but surgeon timing is very different than math for anybody else in the world. So that's kind of a struggle for you. Other things about propofol, it's a very nice bronchodilator. The big reason we use it is because it suppresses your SNS response to laryngoscopy. And then we can also use it as kind of a rescue anesthetic or antiemetic. So you'll see a lot of people get in the habit when they use propofol as their induction agent, they'll keep a cc or two and then take that with them to recovery. So if the patient were to become nauseated there, they've got another 10 or 20 milligrams that they can give that patient. So get in the habit of taking that propofol to recovery with you for that reason. Some people will also just keep an extra vial out in case that happens on the way to recovery. There are some kind of rare, weird problems we wind up with propofol. The biggest one is related to the lipids. What you'll see, especially in patients that receive it for high doses or long periods of time, will develop propofol infusion syndrome. Now, most of us are not doing 58 to 60-hour anesthesia cases, but you may have a patient that's coming from the ICU that's been on propofol for a long period of time, so they may be experiencing some of these effects. I think the ICUs have taken recognition of this, and they've worked really hard to decrease the dosages that the patients are getting through the use of other agents. We're seeing a lot of patients that are getting fentanyl infusions coupled with their propofol. And then I think the recognition of dexmedetomidine is a better agent to provide sedation for patients that you're trying to wean or wake up has helped out a lot with this. Any questions about propofol? Like I said, this will probably be the most commonly used anesthetic agent you guys have when you get to clinicals. Etomidate is probably the second most common. The nice thing about etomidate, and probably the biggest reason that we use it, is because it's very cardiac stable. So if you have that patient that's got a low EF, you don't feel comfortable giving them propofol, etomidate is probably your best choice. In fact, the only time I use etomidate is for patients with very poor cardiac status. Standard dosing is 0.3 milligrams per kilogram. You don't have to change it because they're elderly or sick. So like I said, with propofol, we decrease that dosage. You don't do that with etomidate. Now, that's the book answer. In reality, you may see, because again, these dosages are just a reference point, that you may be able to decrease that dosage and still achieve everything you're hoping for. Again, you can take your time inducing these patients. You don't have to rush through most of our inductions. So you may give like 0.15 or a 0.2 mg per kg dose and then repeat it as necessary. Primarily used in, like I said, cardiac patients, but there are lots of places that still use etomidate as their go-to agent for trauma patients, elderly patients. So something for you to think about. One thing people do forget is this medication is also painful on injection, as is rocuronium. Now, with that being said, hopefully before your patient gets rocuronium, they've gotten some sort of sedative so they don't feel the pain. But etomidate can be very painful on injection. Other things that come into play, we're very aware of the risk of adrenocortical suppression in these patients, and it can happen with a single dose. But I don't know that for some of these patients, there's another good choice. Especially those cardiac patients, and I keep going back to them as kind of the go-to, because our other agent we use, and we'll talk about it in just a minute, for kind of unstable patients is ketamine. But most of those cardiac patients will not do well with the tachycardia that comes along with ketamine. Usually they have a little bit of coronary artery disease already. So if you start increasing their heart rate, now they're getting some demand ischemia, might not be a good choice for them either. And then another big thing that you see with etomidate, it also had the nickname of vomidate for a while because the PONV rate is about 30% for patients. We don't usually see that under general anesthesia because we're almost immediately putting an endotracheal tube into place, but it is a possibility. Sometimes we will use etomidate as our induction agent. Say we're doing like an EGD or a colonoscopy on a sick patient. So what we will, in a normal healthy patient, we would just give them propofol. But because these patients aren't healthy, we will use etomidate to induce and then either continue to administer etomidate or we'll go through and give them little bumps of propofol afterwards to keep them sedated. But the only other thing I didn't say is etomidate usually comes as a 2% or 2 milligram per ml solution, 0.2%, excuse me. And it comes in a 20 or 40 milligram vial. So make sure you pay attention to what you're pulling out of the Pyxis. Kind of the last medication we usually use for induction is ketamine. Things to remember is that it's not a hypnotic agent. It really just causes dissociative anesthesia. As a result of that, your patient is there, but it's almost like the lights are on, but there's nobody home. Eyes will often be open. Sometimes you'll have nystagmus, but they have no clue what's going on. So a lot of times that's nice for us because remember, when we're intubating people, the biggest thing we want them to get out of the sedation, especially if they're unstable, is not remembering what we're doing to them. We also don't want them to have a big sympathetic surge, but we don't want them to remember what's going on here. There's a variety of preparations out there, 1%, 5%, 10%. 50 milligrams per ml is the most common. But as with everything now, we have supply chain issues. So you may see that you're getting a different size vial every day, just depending on what's going on. One of the nice things about ketamine as compared to our other agents is it does provide some analgesia. We also use it a lot of times for patients with chronic pain, PTSD, and some other psychiatric problems as an infusion, as a nasal spray, and also as a orally dissolving tablet. So a lot of preparations out there. The induction dose really depends on the patient. Usually it's 0.5 to 1.5 milligrams per kilogram. Onset time is about a minute. Keep that in mind when you're using it for induction. It's a little bit slower than etomidate or propofol. So when you're timing your administration of neuromuscular blockers, just keep that in mind. One of the nice things about ketamine when compared to the other agents is that it provides retrograde and anterograde amnesia. So even though it took longer than your muscle relaxant to set up, you're probably still not going to have any recall because of that effect on amnesia. Usually it lasts about 10 to 20 minutes. As far as using it as an analgesic dose, a lot of times we'll go down to like 0.25 to 0.3 milligrams per kilogram. You may use it in a variety of settings for analgesia. A lot of times to start cases, we'll give like a 50 milligram bolus, and then we may give like 10 to 20 milligrams an hour. Some places they fusion. There's just a wide variety of uses right now for ketamine. We will also use it in behaviorally challenged patients. So think of like MR patients or pediatric patients. I put catch the kid. You may literally be chasing the kid down the hallway to dart them, depending on kind of how your pre-op works and how mom and dad are and how the kid are. Usually when we do that, we'll go ahead and add in Versed and Robenol because you get kind of a faster onset. You also get the nice drying benefits of the Robenol. It doesn't cause any pain on injection, so that's kind of nice. Like I said, big contraindications we worry about are the tachycardia, and we generally try and avoid using it with MAOIs as well. One of the big issues we run into with ketamine is that it, in high doses, will cause emergence delirium. And when I say high doses, I'm talking about like 4 or 5 milligrams per kilogram. Usually with our standard 0.25, 0.35, we give for analgesia, or lower induction doses like 0.5 to 1 milligrams per kilogram. We don't have a lot of those delirium issues. Other things to think about, it is a very potent bronchodilator. So if you have an asthmatic agent, you may give it as your induction agent. You may just give it as a kind of a adjunct because it does cause bronchodilation. It will increase your secretions. So a lot of times we will pre-treat patients with either Robenal or Benadryl. One of the nice things about ketamine, because it does just cause that disassociation, is it usually keeps their airway tone intact. So there's kind of a alternative train of thought for inducing patients called a delayed sequence induction. One of the reasons we get ourselves into trouble when we're inducing patients is we get in this like rapid mentality of I've got to do this quickly, especially if you've got a sick patient. And as a result of that, we may have a patient that's poorly pre-oxygenated, maybe hypercarbonic. So one of the thoughts with this delayed sequence intubation is we will give them some ketamine and then maximize our ventilatory efforts. So they're well pre-oxygenated. They've blown off a lot of CO2 they're retaining. And then we'll proceed with the induction. So you guys may see that as your clinical practice as well. Problems with ketamine, like I talked about, you may see some hallucinations, you may see some emergence delirium, but it's not extremely common in the dosages that we're giving. Other things that you may see used, dexmedetomidine. It's not really a true induction agent, but what you'll see a lot of times is that dexmedetomidine may be used as the
Hey, Dr.
amnestic agent. Yep.
Before we go on, Gene had a good question. What dose of Robenal would we give?
It depends on your patient. So one of the things you have to think about, we're concerned about the tachycardia already from just the ketamine. Personally, I use Benadryl for all these patients for two reasons. One, I get a little bit of sedation out of the Benadryl as well as some anti-emetic properties. And two, it doesn't cause tachycardia. With the Robenal, you're going to get an increase in heart rate already from the ketamine, and now you're just going to add to it with the Robenal. So kind of your standard dose of Robenal for bradycardia is 0.2 milligrams. So a lot of people, if they're just giving it to dry up secretions, will do 0.1 milligram. But like I said, I would consider using something else just because of, that increased tachycardia. Sorry, Sam, I didn't see your question. She asked, do we give anything to combat the adrenocortical suppression with etomidate? We don't usually. But if you were to get into a case and you've used etomidate for induction and you're concerned about it, usually we go ahead and treat that with 100 milligrams of hydrocortisone. And what you will see that adrenocortical suppression present as is usually going to be prolonged hypotension. Now, when you think back to your treatment of hypotension anyways, that's one of those things we always kind of remember. It's not a common agent that we use for low blood pressure, but it may be something to consider. And there's still a lot of stuff that with the adrenocortical suppression in general, we don't understand. We keep trying to find the magic treatment for hypotension and septic patients. And I think eventually we'll come up with something, but we've tried like vitamin C, we've tried hydrocortisone, we've tried all sorts of different things. But usually that 100 milligrams every 8 hours is going to be your go-to. Does that kind of help with those? And the other thing you'll see is a lot of times people get very set in their ways. So you go train at Hospital X and they do anesthetics one way. When you rotate out to Hospital Y, you only know the way that Hospital X did things. You go to Hospital Y and they do things very differently. The good news for you is that provides you with kind of a wide exposure to different types of anesthesia. The downside is when you keep doing things the way they were doing it at the first facility, they almost think that you're doing it wrong. And it's not wrong, it's just different. But it's human nature to think that different is wrong. Ketamine, I think, is one of those things that is commonly done differently from place to place. So that's something I would just, file away when you start thinking about your analgesic and amnestic plans for that reason. You'll figure out when you first start off, people are very conscious and almost overbearing about what you do as part of your anesthetic plan. but as you kind of progress through clinicals, you figure out your own way. Everybody you work with, in every case you do, you take something away from it. Sometimes it's like that was awesome, I'm going to do that for every case. Sometimes it's that was horrible, I'm never doing that again. But you will retain something from all those different things. All right, back to dexmedetomidine. Like I said, it's not a true induction agent, but we're starting to figure out there may be a lot of benefits for using it during induction or just using it for sedation. Probably the most common benefit that we see is the sedative effect. And then the other big thing that we use it for is the analgesic effect. It's very synergistic with our opioids as well as most of the other medications we give. Other things it may be beneficial for shivering. For a long time, the only medication we had to treat shivering in the recovery room was meperidine, but Precedex seems to work fairly well for that. In the ICU, it's used a lot of times for sedation, somewhat inappropriately. When you think of Precedex, it's a good agent, but it's not good as a solo agent. So like I mentioned earlier, if you have somebody that you're working to wean to extubate, it's a good agent because it keeps them calm. If this is the fresh trauma you got in that's drunk and high, it's not going to be adequate to keep him sedated. So you're going to have to use something else for those patients. The exception to that is a lot of times in our older patients, it may be adequate alone just because they don't quite have the same metabolism and kind of life goals that some of our other patients have. Primary supply of it is going to be 2 ml vials. Usually it comes as 100 micrograms per ml. Standard reconstitution is going to be 4 micrograms per ml. So just depending on whether you take out 2 vials or 4 vials, you'll reconstitute in either a 50 or 100 ml bag. The way it's used really varies from one facility to the next. Some places will provide you with a pre-filled syringe, which is probably the most cost-effective way to use Precedex because it is a little bit expensive. So they may give you a pre-filled syringe with 20 micrograms or 40 micrograms. If you're drawing it up yourself or you're having to mix up a bag, it's fairly common practice to use that for multiple patients. With that being said, obviously make sure you're using clean syringes. You're not pulling a dirty syringe or putting a dirty syringe in the bag, that sort of thing. But you may see that that's common practice for a lot of facilities. So dosing is kind of a question mark for a lot of things. We know if we're using it as a standalone agent what the loading dose is, but it's when you're giving it with other agents that it's a little bit confusing. If you're using it as a standalone agent, a lot of times we do a loading dose of 0.5 to 1 micrograms over 10 minutes. So usually going to be an infusion. And then we're going to continue them on 0.2 to 0.7 mics per kilo per hour. If you administer it too quickly or too large a dose, you'll have hypertension and bradycardia. It's usually pretty transient, but if you just administer it slowly, you'll be fine. If you're using it as an adjunct agent, a lot of times we administer it in doses of convenience, like 4 micrograms, 8 micrograms, just because that's how it's applied. It's usually 4 micrograms per ml. And part of it's just experimentation, figuring out what dosage works well for your patient. Obvious concerns if you're using it. If you have a patient that's bradycardic, I would probably avoid it because it will decrease your heart rate just a little bit. Sam asked, do we need to pull out 2 mLs from the bag first and add 2 mLs to get 50 mLs total? Technically, yes. But with that being said, you'll figure out that it's not as precise as you think it is. Even though the bag says there's 50 mLs in there, 1 ml gets left in the little valve stem. So yes, the book answer would be you would have to take out 2 mLs and then add your 2 mLs. In reality, you're just going to add it to what's there. Other things to think about with dexmedetomidine, it will cause a little bit of respiratory depression, but not very much. It also helps drive secretions. So if you're not using Benadryl or you're going to use Precedex anyways, this may be helpful when you think about with your ketamine. If you have somebody that's high risk for sleep apnea, like an obese patient, it may not be a good choice. It doesn't usually matter so much on the front end of the case, but when you think about waking up that patient, it may be problematic for you because they've been under anesthesia and analgesia. They've gotten lots of medications. They were already prone to obstructing their airway. So it may not be a good choice for those patients. Or if you do use it, you may want to consider front loading the patient. So a lot of those effects have worn off by the back time. We talked about the anti-shivering properties of it. If you use it in conjunction with large doses of opioids given very quickly, you will see that it decreases the muscle rigidity. Most of us are not administering large doses of opioids very quickly anymore, so we don't have that problem. It used to be somewhat common when we were using fentanyl as like our IV induction agent for cardiac patients. And in those patients, we would commonly administer like a milligram of fentanyl, so like 1,000 mics, and that would cause some chest wall rigidity. But most of us aren't doing that anymore. And if you are, a lot of times you're giving a neuromuscular blocking agent pretty quickly, so you don't see that effect. Kind of a drug of choice for people you don't want to fight with. And I mean that literally and figuratively. So you will see that patients oftentimes demonstrate how they got to you. For instance, patients with mandible fractures usually got their jaw broken for a reason. It may have been from a car accident, but it was probably their personality that got them in that situation. So patients with polysubstance abuse, patients with behavioral problems, Precedex makes your life a lot easier because they wake up and you don't wind up having to fight with them. Patients that are experiencing alcohol withdrawal, it's another good agent to consider. One of the issues you run into is that patients that are being treated for chronic pain becomes extremely tolerant of almost all the agents. So as you're able to diversify the medications you're using, you help kind of provide the same service without a lot of the side effects. Other questions about Precedex? Yes, you can totally give it in conjunction with Versed. You can also give it in lieu of Versed. So, patients that you're usually giving Versed pre-op, a lot of times if it's somebody that I don't want to give them Versed, I may give them Precedex instead. But it depends on your provider. But yeah, you can totally give both. You may give one, you may give the other. But it's an option to just give Precedex. And like Brooke said, it works very well on pediatric patients too. Grayson is going to try and dope up his wife and kid with it. May not be a good choice, but an interesting side note, they do have a doggy formulation of Precedex available. I know they use it a lot of times for like dogs that are scared of thunderstorms and stuff like that. So just something to think about. Ayushi asked about using Precedex instead of Versed. Are you meaning for like pre-op sedation or what? Yeah, you could totally do that. My one concern a lot of times for those EVAR cases tends to be, one, the patient's underlying cardiac status, because if I'm going to give an agent that may cause some hemodynamic suppression ahead of time, I may want to avoid that, especially in one of those patients. It also depends on where we're at. Is this an emergent EVAR, or is this kind of something that I can take my time on? If it's something I can take my time on, yeah, I may give a little bit and see what happens, give a little bit more. If it's somebody they're trying to get a stent in pretty quickly, I may avoid it. So Grayson can report back next week and let us know how his Precedex experiment went. If he winds up in jail, it didn't go well. One of the older medications we see used, again, it's usually provider preference, is methotrexate. The biggest time we see it used is for electroconvulsive therapy, but there are people that you will come across that use it as their like sedative of choice. There's some old school ER doctors out there that still use it for a lot of sedations. It's a horrible choice, but That's what they do. The thing they like about it is it's fairly quick onset, and it goes away pretty quickly. Downside, it causes myoclonus, it causes hiccups, even at low doses. I've seen multiple patients that got it and were like, had to come back in and get Thorazine or something else like the next day because they were still hiccuping. At low doses, you will see that it can be used to cause seizure activity. So, like we were talking about for ECTs, it may be beneficial. And then kind of strangely, on the high end of dosing, you can actually use it to treat seizures. It's very irritable to the airway, so it may not be a good choice for those sedations. Don't tell those people to do it anyways. But like I said, the biggest thing is using it for ECTs because it's not going to cause any sort of depression of the seizure. Most of the medications we use will cause some depression. Propofol will, ketamine will. Etomidate may actually provoke seizures, so it's probably not a good choice. You can also use it for cardioversions because they're generally not too painful, and they're very quick procedures. And then, like I said, the big advantage is that for the seizure patients is that it allows them to continue to seize, so they're able to map the actual focus of the seizure. All right, any questions about sedatives before we move on to opioids? All right, like we talked about, morphine is kind of the standard opioid agonist. Post-op pain, usually 5 to 20 milligrams IV titrated in. One of the big things you have to watch when you transition from fentanyl or Sufenta or Remy to morphine or hydromorphone is that they do have the potential to cause respiratory depression for long periods of time. And the sidebar asterisk is a lot of times we will put either Duramorph, fentanyl, or Dilaudid in our epidurals or our spinal agents. If you use it as a neuraxial agent, it can cause respiratory depression for even longer. So even though you're only using a very low dose, you may see that there's some respiratory depression for up to 24 hours. It does cause dose-dependent histamine release. So if you have somebody that's already hypotensive, it's probably not a good choice. You can use a histamine blocking agent like Benadryl to prevent that. But usually if it's to that point, we probably just avoid using morphine and go with something else. And the big reason we run into a problem with morphine on the back end is because it has 2 active metabolites. So not only does it stick around a while because of its metabolite, but if you've got people that are not able to metabolize it very well, think about elderly patients, liver or kidney issues, it may be there a lot longer than you want it to. Dilaudid is kind of the high-end opioid we use. It's a lot more potent than morphine. The good news is it doesn't cause the same histamine release that you do see with morphine. One of the cautions is that its onset is a little bit more delayed, but you have a longer duration of action. So we get in this instant gratification phase, especially in the operating room where we give a medication and we want it to work immediately. Remember that especially Dilaudid, you're probably looking at 5 to 15 to 20 minutes before it works. So let it work before you give another dose so you don't wind up burning yourself, especially as you start talking about respiratory depression in patients. A lot of times you will see early on in cases we use something gentler like fentanyl. And then on the back end, we'll use morphine or Dilaudid because it provides analgesic coverage into PACU or to the floor or to whatever else you're going to. Very low doses for patients. Usually we'll reconstitute it to 1 milligram per ml and then give a 0.5 milligram at a time. But again, there is some variation to that. Fentanyl is the most common analgesic that we use, dosing 1 to 5 mics per kg during the first hour of surgery. You can also use it as an infusion. As we, again, run into all these weird supply chain issues, you may not have remifentanil, you may not have sufentanil, so you may actually wind up using a fentanyl infusion. Generally, because it's a lot of extra work for me to create another infusion, I will just bolus it, but there are places that will use fentanyl as an infusion. When I was in residency, our neuroanesthesiologist loved fentanyl for everything. So all our spines and cranies would get fentanyl instead of Remy or any of those, even if we were doing nerve monitoring. Standard supply is 50 mics per ml. or standard concentration is 50 mics per ml. The supply varies. The most common ones we see are the 2 ml 100 microgram vial or the 5 ml 250 mic vial, but they have 20 ml vials out there. They also have 10 ml vials, so make sure you pay attention. The other caution is that there's a lot of things in 1 and 2 ml ampules. So you could have fentanyl, you could have epinephrine, you could have Nubane. There's lots of stuff out there. So make sure you pay attention to what you're grabbing with an ampule. Meparidine's primary use from our perspective is post-op shivering, but you will see, even though it may not be the best choice, a lot of pediatric centers use meparidine for their analgesic medications. Like I said, probably not the best choice, but you do see a little bit of increased incidence of shaking in recovery in pediatric patients. So that's one of the big reasons. Personally, I think the pediatric patients just benefit a lot more by getting Precedex, but that's Brian's opinion. Sufentanil is generally used as an infusion for like total IV anesthetics or as an analgesic adjunct during longer cases. But you will see people that use fentanyl or sufentanil for induction, usually in a dose of 0.5 to 1 mics per kilo. The nice thing is it's usually in the same concentration as our fentanyl, 50 mics per ml. Most of the time, you will wind up having to reconstitute this to do an infusion. So usually we wind up with a 2 ml vial of 50 mics per ml, and then we put that in a 100 ml bag. So now you've got 100 micrograms and 100 mLs. Nice thing about Sufenta, especially as you think about long-term stuff, is it's very cardiovascularly stable. So when you're looking at doing like a TIVA, it may be helpful to have something like Sufenta or remifentanil and not have to administer quite as much propofol just because of the cardiovascular stability. One of the nice things about using Sufenta during cases is that it sticks around a lot longer than Remi. So usually if I use remifentanil during a case, I'm going to have to give them another analgesic before they wake up so they're not in pain. Sufenta, you don't have that problem. And then finally, remifentanil, it's a very short-acting, ultra short-acting opioid. It's metabolized by plasma esterases. So that's kind of nice when you start thinking about patients with organ dysfunction. A lot of times we will use this for total IV anesthetics that we want to wake up quickly. For instance, I did a carotid the other day. We used it because he woke up immediately, was able to move everything. We were able to do a quick neuro evaluation. Also commonly used for neuro cases for that same reason. You can use it as a bolus dose. One of the kind of interesting things is sometimes you will see that 1 mic bolus is used in lieu of succinylcholine to cause respiratory arrest for intubation. So if you had somebody that you wanted to use sucks but had contraindications, you may consider using remifentanil instead. Downside of Remi is it's extremely expensive, so it's not used a lot of times other than for kind of those select cases. So just kind of an overview, you will also see a lot of PO opioids used. The most common one is, from our perspective, is going to be oxycodone, but we are starting to see a lot of tramadol used as an analgesic as well. The other thing you have to think about with opioids is there are a lot of partial agonist-antagonist drugs that you may use for pain, or you may have patients that are taking. The most common time we see those used, especially like Stadol and Nubane, is in OB. Outside of OB, you may see methadone and buprenorphine used for chronic pain patients. So those are just kind of the encounters you run into with those patients. The one nice thing about using these is a lot of times they will not cause any sort of pruritus, but you can still get analgesia for these patients. We only have one real opioid antagonist we use, naloxone. primarily going to be used in doses of 40 to 80 micrograms per IV. It's usually supplied in a 400 mic per ml vial, but there are other concentrations out there, so be very cautious. If you go old school, we used to give 2 milligrams to everybody. Well, what we have to think about is, why are we giving this to our patients? Usually it's because they got too many opioids intraoperatively and we want them to breathe on the back end. So what we do, instead of giving that big 2 milligram bolus, is slowly titrate in, 40 mics at a time, just enough that they return their respiratory effort, because we want them to breathe, but we don't want them to be in pain. You may also use it to treat some of the opioid-induced side effects. We talked about the pruritus, but you may also use it for like urinary retention, biliary spasm, that sort of thing. Just a caution, if you use this on patients, it may wear off before the narcotics or the opioids you were treating, so be very vigilant. Sometimes if patients receive Narcan, they have to stay in the recovery room or the facility even longer. So make sure if you use it during your case that you do tell the PACU nurse. That way, the patient doesn't get in the car to go home and all of a sudden the Narcan wears off and they're not breathing. Benzodiazepines are a primary anxiolytic agent, but we may also use them for sedation. We may also use them to treat seizures. And then we may also use them to cause some skeletal muscle relaxation, especially in patients with back pain. This is just kind of the hierarchy as far as potency goes. Ativan's the most potent, then midazolam, then diazepam. And they're usually in a better ratio of 5 to 1. Cautions that you run into, some of the benzos need to be refrigerated. For instance, Ativan generally has to be refrigerated, so its availability may not be quite as good. And then the other part of it is, as far as administration, because it is refrigerated, it tends to be very thick. So it takes a while to draw it up and administer it. Midazolam is the most common agent we use. So things to think about with benzos. From a cardiac standpoint, with our sedative dose, you very rarely get cardiac effects. But if you're giving a large dose, like you could use Versed as an induction agent, you may see that there's pretty significant drop in your hemodynamic properties. They do tend to cause respiratory depression, which usually isn't an issue if you're giving it as an anxiolytic agent. But if you're giving it to somebody as a sedative, it could be problematic for you. The other thing you have to think about before you give this to a patient is, what is their pulmonary status? So if you have somebody that's maybe large, maybe they don't breathe well anyways, you may not want to sedate them or give them that anxiolytic dose, because you're never going to be able to get them pre-oxygenated. So not everybody has to have Versed. We get in this habit of like doing cookbook anesthesia. And if your patient doesn't need it, you don't have to give it to them. But I would be extremely cautious, like I said, with those patients that are not breathing real well before you give it to them. The other thing is, people tend to have weird reactions to midazolam, even in doses as low as like 1 milligram. So a lot of places, if you give somebody a dose of midazolam, they have to go on a pulse ox and be monitored. Some places you will give the midazolam to your patient in pre-op. Some places you'll write an order for it. The good news is there is a reversal agent for all our benzos, flumazenil or romazicon. Generally, we won't wind up using it, but there will be times that maybe you do a case, maybe it's one of those neuro cases or like a carotid or something else, and the patient's just not waking up. So we go through and we try and get rid of everything that we can think of before we go to the obvious cause of, they've had some sort of cerebral ischemic event during the case. So in that case, usually we'll wind up giving them that IV dose to reverse the little bit of Versed they got. You may wind up giving them Narcan as well to reverse the benzos. Be cautious, because in larger doses, you can cause seizures. But it's pretty quick onset. You can repeat it as needed up to 1 milligram. But generally, one dose will kind of give you an idea if that's what's going on or not. Nausea and vomiting agents. There are a ton of agents out there. I'm not even going to try and go through all of them. We're just going to touch on the most common ones. As I've said several times before, being nauseated and vomiting is a big dissatisfier for patients. So even though I don't think we should give medications just because, I think that giving a medication to prevent nausea and vomiting, or at least reduce the likelihood of it, is a pretty good reason. Almost every case I do winds up getting Zofran and Decadron. Patients that are increased risk, I will give even more antiemetic agents. Usually my next choice is Benadryl. I may add in metoclopramide. And then something else that I think you have to definitely give consideration to is stuff like Haldol, Droperidol. Those sorts of things also work very well. Personally, I'm not a big fan of scopolamine patches. Part of it's just because of timing, but it also tends to cause undesirable side effects for people. You've got somebody that's nauseated, and now you've just dried up all their secretions, so they feel like their throat's very dry, thick. It will also cause some behavioral problems. And then from a timing perspective, a lot of times we don't give it when we need to. The patient really needs to have it on a couple hours beforehand. So it may help out a little bit on the back end, but it may not. Lots of patients I've talked to that have had scopolamine patches felt like it was the worst part of the procedure. I don't know if anybody's had any personal experiences like trying them on cruises or whatever, but I'm not a big fan. But with that being said, I think it's definitely something you need to consider if you have somebody that's extremely high risk for nausea and vomiting. The other thing I would think about in those patients is avoiding triggering agents if you possibly can. This is just kind of an overview of things to think about with the nausea and vomiting agents. Like I said, I give Decadron to almost everybody. Even in my diabetic patients, I'll just lower the dosage. Zofran is fairly safe to administer. Just be very cautious with your QT interval. Dosing for Decadron's 4 to 20 milligrams, Zofran 4 to 20 milligrams. Droperidol was very tough to find for a long time, but we're starting to see more of it come back onto the scene. Usually we give it in a dose of 0.65 milligrams. Reglan works well as an antiemetic and also increases gastroparesis. One thing to be cautious of is that it can cause anxiety and increase extrapyramidal side effects. So just be cautious in giving it to patients that haven't had any sort of sedation, because they may go crazy. I had a partner that gave a dose one time to somebody that hadn't gotten any Versed, and it was all he could do to keep them from canceling the case because they were refusing everything after that. They'll just have very irrational behavior. Like I said, don't forget about Benadryl. In addition, it's a very potent antihistamine. When we're using it as an antiemetic, though, we can give a lot lower doses than we do for like allergic reactions. So think about like 6.25 milligrams, 12.5 milligrams, that sort of thing. We talked about scopolamine patches. Also, don't forget about Pepsid. It helps decrease the gastric acid, but it can also help with nausea and vomiting, and it's actually FDA approved for morning sickness. And if you know anything about drug approval, getting a medication approved for pregnant women is quite an accomplishment. We primarily use phenergan as a rescue drug now, just because of issues with infiltration of IVs and extravasation. It also causes sedation. So when you're trying to wake somebody up and get them out of the hospital, it may not be your first choice. And then, like I said, propofol works very well as an antiemetic. And then finally, one of the newer medications out there, Apredin or Emend, works very well in high-risk patients. It is a little bit more expensive, but it works fairly well for nausea and vomiting if it is available at your facility. All right, we're going to move on to paralytics. Most of these are subsidiaries of Curari. So after Grayson figures out how Procedex works, he can be running around with little blow darts chasing dogs in the neighborhood or something, and let us know how his time goes as a skillful hunter.
Dr. Cornelius.
Yep.
May I ask a question about the Zofran and Decadron doses?
Sure. Yep.
So on the little Tex West laminated guide thingy, it's a little different than what you just said. So I'm just curious, yep. As long as we know range worthy, we should be all set, or should we go more off the laminated guide?
as long as you know the range, like I've said all along, there's a variety of dosing. It's just a reference or a jumping off point for you. You work with Bob today, and he gives 8 of Zofran to everybody at the start of the case. You work with Brian, and he gives 4 at the beginning, 4 at the end. Just be familiar with, kind of what's out there.
Okay, great. Thank you.
Yep. All right. For a long time, succinylcholine was our go-to neuromuscular blocking agent. Just because of the ill effects that it does provide, we've kind of abandoned Sux for a lot of our patients. Big thing to think about, it's our only depolarizing agent. And as a result of that, the medication itself, it just causes a lot of problems. Biggest ones, be cautious with patients in hyperkalemia or with existing renal failure. Also be cautious with patients that are potentially MH susceptible. And that's the big thing. The nice thing about it is it does provide rapid onset and go away very quickly. The downside of that is people kind of get in their heads that if something bad happens, it's a safer agent because the patient will be back breathing. Unfortunately, for those patients, they will not start breathing fast enough to prevent an adverse outcome. So trading the rapid elimination time for the ill side effects that come with it is probably not the best choice. So one of the big reasons for that is we've started kind of considering the role of succinylcholine and using rock for a lot of more things just because of that. Nimbex or cisatracurium is a more potent version of atracurium. And the nice thing when you compare it to atracurium is it doesn't cause any histamine release. You don't see a whole lot of dosage change with age or illness. It generally doesn't accumulate because it goes away very quickly. The downside of a couple of downsides of Nimbex. One, it has to be refrigerated. 2, it's very expensive. 3, it doesn't work very well. I would never use Nimbex for induction if I had any other choice because even in the appropriate dosing, you just don't see it work very well. The advantage of it, and the biggest reason we wind up using it is that it's kind of our drug of choice for renal failure, just because it is metabolized in the blood independent of any sort of organ function. Vecuronium and Norcuron is kind of the older version of Rocuronium. So when you start thinking about comparisons between the two, Vecuronium has a longer onset time and a longer duration of action. The nice thing about Vec when compared to Roc is that it's a lot more predictable. Usual intubation dosage is 0.1 mg per kg. Afterwards, it's going to be 0.05 mg per kg for maintenance paralysis. Big hepatic metabolite or metabolism. It does maintain an active metabolite, so you may have some issues with prolonged duration if you've got patients with liver or renal issues. One thing you will see for a lot of these agents is there's redundant systems. Usually if it's metabolized in the kidneys and they don't work, then it kicks over to the liver or vice versa. So just because you have one organ system that doesn't work the way it's supposed to, doesn't mean it's a contraindication for usage. So that's why you'll see a lot of times, even in patients that do have renal failure, that people will still use rocuronium because the liver still works okay. If you had somebody with widespread organ failure, I would be cautious using any of the agents, but Nimbex may be your choice. But just on the back end, don't be surprised if they stay relaxed for a lot longer than you wanted. One thing that's different about acuronium is it comes as a powder that you have to reconstitute with sterile water. So you're going to reconstitute that to 1 milligram per ml. Rocuronium is probably our most commonly used neuromuscular blocking agent right now. Your initial dosage is 0.6 mg per kg, but as you increase your dosage towards that RSI dose of 1.2 milligrams per kilogram, it speeds your onset. You can also use it as for maintenance paralysis. The one thing, like I talked about the other day, is you use rock for maintenance paralysis, you will get kind of weird periods of action. So a lot of times people will use rock as their initial paralytic and then transition over to VEC because it is more predictable. Good news, it's generally not metabolized, it's excreted intact, so you don't have some of the issues there. As I mentioned, when one system isn't working well, you may have benefit of using another system. And just be cautious in elderly patients that it may not go away quite as fast as you want. So before, when we were using neostigmine and glyco as our primary reversal agent, a lot of times we would have a hard time getting neuromuscular return in elderly patients. Now that we have Sagamidex available to us, we have kind of a little bit more safety there. So you may use Sagamidex in patients just because they're older. So with that kind of segue, we're going to talk a little bit about reversal of our paralytic agents. We do not reverse non-depolarizing agents, so we don't reverse succinylcholine. It's just it just self-metabolizes and goes away. The longer-term agents, rocuronium, vecuronium, pancuronium, do have to be reversed. So the most common agent we use right now is neostigmine. But again, with supply chain issues, sometimes we run out of one medication, so you have to use something else. Usually in pediatric patients, we'll use edrophonium. And then in adults, a lot of times we'll use pyridostigmine. But now that we have Sagamidex available as a second line agent, even if we run out of neostigmine, a lot of times we won't have to go to one of these medications. You may also see patients that come in taking physostigmine. We can use that to reverse our paralytics, but it can cause some weird behavioral things. So we generally won't use it at all. But it is an option for you, especially if you happen to be in a weird situation or some sort of supply chain issue. So medication-wise, edrophonium onset's like 1 to 2 milligrams, which is fairly rapid. Neostigmine is a little bit longer, 7 to 11 minutes, and then pyridostigmine is a lot longer. So one of the things you have to think about is timing whatever anticholinergic agent you're using with your neuromuscular blocking reversal agent to make sure they occur at the same time. And the reason we do that is all these neuromuscular blocking reversal agents will cause bradycardia. So we're using an anticholinergic agent to counteract the effects of that. Duration of action for edrophonium is the shortest. So think about that. If you have somebody that got a large amount of paralytic and then they get reversed with edrophonium, you have the potential for them to be reparalyzed because you may only get a 20-minute duration of action. Neostigmine is kind of the intermediate range, 40 to 60 minutes, and then pyridostigmine is usually about an hour and a half. The most common pairing with our neostigmine is glycopyrrolate. The big reason is you have about the same onset time, or the glycopyrrolate is faster. And the reason for that is that we want to make sure that our heart rate is up or stable before we give something like neostigmine that's going to cause bradycardia or potentially asystole. You don't want your patient to go into asystole and then have their heart rate pick back up. So if you're administering the medications, a lot of times what we do is combine the two together. So I'll take a 10 ml syringe and I'll put my intended dose of neostigmine and my intended dose of glycopyrrolate in the same syringe. If you're administering them separately, you want to make sure you give the glycopyrrolate first. As I mentioned, Sagamidex is kind of the new neuromuscular blocking reversal agent. Originally, it had very tight controls on when it could be used. It was just for like obese patients or somebody that you didn't want to have to give the anticholinergics to. So think about like a patient with coronary artery disease. You may not want to give them an agent that's going to cause tachycardia because you're going to have demand ischemia. So giving them something like Sagamidex may be beneficial. Sagamidex is far more expensive than neostigmine and glycopyrrolate. Originally, neostigmine and glyco were pretty cheap, and Sagamidex came out and it was extremely expensive. So being a nice capitalistic society, the company that produces Sagamidex went out and bought the vast majority of neostigmine. And as a result of that, they drove the price up. So Sagamidex was not so expensive anymore compared to now expensive neostigmine and glycopyrrolate. So it made it a little bit more palatable for hospitals. The ASA has also come out with a revised list of indications for using Sagamedex. So part of that is driven by the fact that it's a little bit safer agent. We figured out that giving patients neostigmine and glycopyrrolate results in kind of prolonged duration of action of the neuromuscular blockers, and it can lead to increased hospital as well as PACU adverse events. So using Sagamedex seems to reverse those or decrease them at least. You can use Sagamedex with VEC. You can use it with ROC. It's not FDA approved for pancuronium, but it also works well with them. Other things, you can use Sagamedex as an emergent rescue agent. So it's really dependent on how much neuromuscular return your patient has, the dosing that you're going to give them. So if you've got somebody that's got a fairly light blockade to medium blockade, our standard dose is 2 milligrams per kilogram. Whereas if you have somebody that's got a little bit more of a deep blockade still, you'll increase to 4 milligrams per kilogram. Or say you were to give somebody like that 1.2 milligram per kilogram dose of rocuronium, and then for some reason maybe you can't get them intubated or you need to immediately reverse them, you can give a dose of 16 milligrams per kilogram of Sagamedex and get immediate reversal. One thing that you will see is that patients have almost like a violent reaction to getting Sagamedex. They immediately start breathing and moving. Whereas using a lot of the other agents, you don't have quite that same emergence. So just be cautious about when you give it during a case. Any questions about neuromuscular blockers or reversal or any of those sorts of things? Grayson asked if someone is slightly tachycardic, is the glycopyrrolate still usually necessary? Yes, it is, but a lot of times what I will do is just decrease the dose. Like I talked about the other day, in a standard administration, you're going to give a 1-to-1 ratio of neostigmine to glycopyrrolate. So neostigmine is 1 milligram per ml, glycopyrrolate is 0.2 milligrams per ml. So I will match up 1 ml of each. If I have somebody that is already tachycardic or somebody I'm concerned about becoming tachycardic, I'll decrease the dose of glycopyrrolate by 1 ml. So instead of giving, if I'm giving 5 mLs or 5 milligrams of neostigmine, I would only give 4 mLs or 0.8 milligrams of glycopyrrolate. And that seems to work out fairly well in preventing the tachycardia. A caution with that, if you're using neostigmine and glycopyrrolate in pediatric patients, always give the full dose just because they are so heart rate dependent. Ayushi asked about using magnesium to prevent fasciculations from succinylcholine. I don't know. I would have to see what the dose needed to do that would be. My issue would be giving it close enough, if it even works, and I don't know that it does, giving it close enough to the administration of your sucks in a large enough dose that it would cause enough muscle relaxation to prevent it. But I honestly don't know. I've never thought about it or tried it, just because there are other options out there. Our standard cocktail to prevent fasciculations is either administering a non-depolarizing agent like ROC or VEC ahead of time or giving like a 1/10 dose of sucks. But I don't know. That may be something for you to take a look at. I don't know what research is out there about that, but that may be something beneficial, especially like as we're looking at using more magnesium for analgesia. All right. This is just kind of the usual anesthetic. And I say that with air quotes because there is no usual anesthetic. This is just one of the more common ones. All of your anesthetics need to be tailored to the patient. But usually we start off with Versed and pre-op as an amnestic agent or an anxiolytic. Like I said, if your patient's not anxious, you don't have to give them medications. If your patient's already sedated, you don't have to give them a sedative. Think about a patient you bring from the ICU that's already sedated or has the sedative infusion going. You're not going to give them 200 milligrams of propofol to start a case. You're not having to put a breathing tube in. So kind of let the patient drive your anesthetic for a lot of things. but don't do things just because that's what you always do. Lidocaine we use for two purposes: to blunt the pain from the injection of our propofol or etomidate, and then to help with the blunting of the sympathetic response. Usually we'll give that a minute or two before we actually induce the patient. Same thing with our fentanyl. We're not just using it as an analgesic, we're also going to use it to help blunt the sympathetic response for that patient. Induction agent, think about why you're going to use what agent and the dosing that you're going to use. We give you guys kind of a reference or a starting point for the dosage, but there's a lot of factors that come into play. Like I said, one of the biggest ones is the patient's cardiovascular standpoint. So that may affect what dosage you're giving, what medication you're giving, and whatnot. We talked about some of the TIVA stuff as far as the infusions you can use. For your paralytics, think about what agent you're going to use, your dosing, why you would use each agent, why you wouldn't use each agent. Like I said, it's common to use a combination of things, especially if you use succinylcholine for induction. It's very common to come back and give ROC or VEC for long-term paralysis. But think about why you're doing what you're doing. Don't just do it because that's what you wrote on your care plan or what you do for all your other cases. Remember, if you're using short-acting stuff, that you need to complement it somehow with something that's longer-acting. So like if you're using Sufenta, or especially if you're using Remy, provide your patient with some long-term pain relief. Give them some morphine or Dilaudid or something like that on the back end. Like I said, being nauseated is a big dissatisfier for things, but you can also run into problems. If you give a ton of antiemetic agents, they all have consequences as well. Like I said, a lot of those will cause QT prolongation. So if you have somebody whose QT interval is already prolonged, it may not be a good choice to give them multiple antiemetic agents, especially if they're all going to contribute to that. Giving somebody Zofran and droperidol might be a bad idea. So think about hitting like each of those receptors as opposed to using one agent that hits multiple receptors. And then on the back end, think about your reversal agents, what you're going to give, why you're going to give it, incorporating not only your patient considerations, but also the facility-specific policies, because that may really guide when you can do what you can do. There are a lot of different ways to perform an anesthetic. There are tons of medications out there. You're really getting to kind of the fun part of school now, where you get to go out and start applying and learning and doing all the things that you've picked up in the classroom. There's so many different ways you can do things. You can use lidocaine as an infusion for pain relief. You can use MAG. Like I said, I don't know about as far as preventing fasciculations, but magnesium is pretty beneficial for a lot of people too. Is this a case I can do with a block and sedation, or a spinal or an epidural? Every case doesn't have to be done as a general anesthetic. That's kind of our default for everything, but there's lots of ways we can do these cases. You may put a spinal in and do an LMA. You may do a block, do a spinal, and do an LMA. Part of it is your decision for the patient. Part of it is the facility practice. Part of it's the surgeon. Part of it's the patient. There are so many factors that come into play with this. So like I said, there's so many things you could talk about for each of these agents. You guys have spent a year and a half getting ready from a pharmacological standpoint for this. We can't go over all those things. Take your time, review it. Before you do these cases, make sure you pay particular attention to the medications. If there's a medication you don't use very commonly, or you're not quite as familiar with, make sure you brush up before you do the case. You don't want to be giving a medication that you don't know everything about. And it's okay most of the time if you're not sure to say, I'm not sure. If you're saying I'm not sure to everything, you probably need to be studying more. But there are things that come up that people don't know. There are so many medications that are new, or we're using them in different means, that you just can't be expected to know everything, but we want you to try as hard as you can. Certainly for the common medications, you need to be very familiar with them. But some of the less common or newer medications, it may be a little bit harder to do that. But the big thing, like I said, is know these medications, understand that there is not just one way to do any of these things. Don't be a one-trick pony. Figure out lots of different ways to do these anesthetics, because you never know when you're not going to have an anesthesia machine, or you don't have propofol, or there's no Zofran in the hospital. If you only know one way to do these things, when one of those incidents happens, you're out of luck and kind of sends you into a panic mode. And you'll figure out, like I said, there's lots of different ways to do it. And you may like a different way than what most people do. That's totally fine. All right. So Gina said, so we give the glycopyrrolate and it does cause tachycardia, causing hemodynamic instability. What would be our next drug of choice to counteract that? Two things. One, the tincture of time, because you give them medication and it causes tachycardia. Second thing, if I'm just treating tachycardia, what do you think would be a good choice? Or what does the class think would be a good choice? Think about the medications we talked about. Yeah, exactly. So if I've got somebody that is purely tachycardic, esmolol is probably going to be my drug of choice. If they're tachycardic and hypertensive, then I would consider labetalol. If they're just hypertensive and they're bradycardic, then I would probably go with hydralazine. But esmolol would be my drug of choice for just tachycardia. The other thing I would think about in that situation, you have to kind of think about where that fits into your case. And sometimes we don't know exactly what's going on. It's just, working through a kind of our differential. So usually we're reversing our patient on the back end of the case. So surgery is finishing up. We're lightening our anesthetic because we've turned off our volatile. Maybe we have not given them as much analgesia because we want to make sure they're going to breathe. So make sure the tachycardia you're seeing is caused by that esmolol, not caused by the lack of anesthetic gases, them waking up, that sort of thing. So just don't assume that one thing has caused another. There could be multiple causes, so make sure you kind of work through those. The other thing you may do is give the patient a little bit of propofol, but it really just depends on kind of your feeling for the case, your feeling for the patient, how they've responded or reacted to different things. So, but good question. What other questions do you guys have?
Hey, Dr. Cornelius, real quick on that fentanyl, you said that they use those for neuro cases. Are you just giving naloxone just to get them up, and then you wouldn't give it again, and just use that have that pain effect for after?
I didn't hear the first part of what you said.
You said sufentanil was for neuro cases.
Yeah.
Since it lasts longer, during emergency, you would give naloxone just to wake them up, right? And
no. You wouldn't have to reverse it. So when I say sufentanil lasts longer, it lasts longer than remifentanil. Remifentanil, you're looking at turning it off and it's gone like a couple minutes. So sufentanil lasts longer than that, but your duration of action is nowhere near like fentanyl or morphine or Dilaudid or any of those sorts of things. So very rarely will you have to reverse sufentanil or Remi because they do go away so quickly. But if it was, are you talking about to get like a neuro exam on somebody?
Well, I was from the Texas reference guide. The duration is hour to an hour and a half for sufentanil, but I know Remi is 6 to 8 minutes. So I was wondering, I know with the Remi, when you turn it off, then they're gonna wake up pretty soon. But if it's a sufentanil drip, I guess assumed it would stay in their system a little bit longer, and I'd be worried about respiratory depression towards the end of the case.
So what you'll see happens, kind of the classic pattern with sufentanil, is they will start breathing. They will experience respiratory rate depression, but they will have really great tidal volumes. You'll see when you get to clinicals and you use sufentanil, a lot of places will even call it like a sufenta wake up. You'll have patients that are breathing like 6 to 8 times a minute, but they're taking like liter to liter and a half breaths. So you'll have kind of respiratory depression technically, but it's not problematic respiratory depression most of the time. Does that make sense?
Yeah, that makes sense. Thank you.
Yeah, very rarely will you have to reverse either sufenta or definitely Remi just because they do go away very quickly. Gina asked, when you give a longer acting opioid on the back end, if you're using sufenta or Remi, when would you give those after shutting the infusion off? And would you worry about having too much on board causing delayed awakening. So I don't want to have my patient not be in pain. So usually what I do is I start either actually doing it or thinking about turning the Sufenta or Remy down. I'm going to go ahead and give that other medication so they're covered in that period. But a lot of times what I'll do is I'll start off with a lower dosage of one of those medications. And then, like I said, kind of let them drive it as they're waking up. So I give them a little something so they have coverage. And I can't tell you what a little something would be for that patient just because there's too many unknowns at this point. If you're using Dilaudid, like I said, a lot of times I'll start off with a 0.5 milligram. Or, if it's somebody that I don't want to use Dilaudid, maybe I've got like an older patient or somebody I'm worried about respiratory depression, I may just give them like 25 mics of fentanyl. And then as I start turning down the Sufenta or turning the Remy down, let them start breathing and seeing kind of how they respond to the things. And then I can work in more over time. I definitely worry about having too much on board and them not waking up or not wanting to breathe, but I don't want them to be in pain either. And that's part of the hard part of anesthesia. And part of the reason I say there's not like a magic recipe or a cookbook to, do this or do that, because you have to see what happens for all these interventions. You can do the same case and do the same thing 4 different times in a row, and it doesn't work, same way on any of those patients. So that's just part of doing it and figuring it out. Kimmy asked about when reversing with Sagamidex, you said patients can wake up more violently. Does giving the drug slowly help or prevent this, or giving adjuncts like Precedex? Yeah, the big thing there, I would not give it more slowly. I would also not slam it in there. There have been case reports of bradycardia and asystole with rapid administration of Sagamidex. I personally haven't caused it, but I know when we first got Sagamidex, we had the 5 ml vials, and we're giving a lot higher doses just because we didn't have any personal experience with it. And I know there were some periods of bradycardia and asystole, very transient, but enough to make your heart stop too, with rapid administration. So we get very cavalier with giving our medications. Sagamidex is something you don't want to just slam in there. But so the second part of your question, yeah, if you have your patient comfortable with Precedex, or even if they're still under like a MAC or half MAC of gas, or you've given adequate amount of opioids or ketamine or any of those sorts of things, it helps reduce that. But it's just something that you see with Sagamidex that you won't necessarily see so much with neostigmine and glycopyrrolate, just because it's got a gradual onset as opposed to a quick onset. And I don't want to make it sound like the patient's going to wake up and fight. It just may be a matter of like they start coughing and bucking, which, if somebody's still in the middle of closing when they start coughing and bucking, that's kind of a big dissatisfier for the surgeon. On the other hand, like with that neostigmine and glyco, because it's a gradual process, they'll be able to finish sure it's not quite as significant. But that's more what I mean by that. But yeah, if your patient's comfortable, it's generally not quite such a big deal. You can also do things like giving lidocaine bolus, almost the same dosage you would give an induction. That'll help with that as well. All right.
So
any other questions?
Question
Yep.
about the spinal doses that's on the reference sheet. So when we had talked about spinals before, we had said like with bupivacaine we would give 0.75%. So to get a T4 level anesthetic, we would be giving like 10 to 20 milligrams. But this sheet says like 1.2 to 2.5.
Were you talking about spinals or epidurals?
Spinals.
Okay. So spinals, you're going to be giving, it depends on the patient's height. Kind of my go-to reference point for that 0.75% is if I have a patient that's 5'4", I will give 1.4 mLs. And then there's not like a magic titration table from there. But that's just the reference point I kind of keep in my mind.
So with that dose you just said, that I mean that would be closer to like 14.5 milligrams, but this sheet says 1.2 milligram to 2.5. So that's like a pretty.
I bet that's supposed to be milliliters, not milligrams.
Oh, okay. All right, that makes more sense.
I hadn't noticed that. I'm glad you caught that.
Oh, thank you.
Yeah, because that would be yeah. So yeah, from a milliliter standpoint, it should be more like 1 to 2.5. Yeah, that would be a crazy dose from milligrams. But I hadn't noticed that. Thank you. All right. What other questions do you guys have?
Hey, Dr. Cornelius.
Yep.
Going off the local anesthetic, is it the solution that makes it hyperbaric like dextrose, or
Yeah.
specific?
So like with the bupivacaine, it's got
Yes, sir.
dextrose added to it. So you'll get a variety of locals, and you really have to pay attention when you, especially like if you go to like our Pyxis generally just has what we use in it. But say you go to like the core Pyxis, you may have like 5 different Marcaine half percents. One will have epi, one will be plain, one will have dextrose. There's a lot of different stuff in there, so you've got to pay attention to what you're getting in there. But yeah, it's the dextrose that makes it hyperbaric.
Okay, I just forgot. So thank you.
That's okay. Yeah, and you'll see people try to create their own versions of it. Like you don't have, Marcaine with dextrose, so they try to make their own. I think that becomes problematic. You probably just need to evaluate what you have and change your patient positioning if need be. But maybe you've got somebody with like a hip fracture or something, and you don't want them to lay on their broken hip, but you do want to have it as the downside. So you may have to use something that's not hyperbaric so it doesn't settle. Does that make sense?
Yes, sir. Thank you.
All right. Any other questions? All right. I will see you guys on Tuesday for exam. Like I said, a lot of it is going to be scenario questions. That's part of the reason I wanted to talk through a lot of this stuff so you guys kind of understand what to think about and that sort of thing. But know these dosages and just how to apply it. And if you guys think of any random questions over the weekend, just let me know. I'm happy to kind of work through things.
Thank you.
Thank you, Dr. Cornelius.
Yeah, no problem. You guys have a good week.
Thank you.
Hey, Dr. Cornelius.
Yes, sir.
Still there? Do you mind posting this on Canvas? I had emailed you about having troubles with Teams and where you're watching the lectures.
Yeah, it's on Canvas. If you scroll down, here, I'll share my Canvas with you and show you. All the lecture videos are down on the bottom with the YouTube link. One second. Canvas is taking its time. Especially now that we have to authenticate every time. Are you able to see this okay?
Yes.
All right. If you go to modules, you go all the way down here to the bottom. It's not that far. Sorry. Here are the YouTube links. And this one right here has got the Pharm first lecture, and then the second one will be below it.
Okay. Perfect. Thank you. I'm not sure what was going on. I was just trying the Teams yesterday, and all the videos that I normally watch were just gone. So
Who knows? And I guess they're coming out with a new version of Teams I saw yesterday. This is like the classic version, and then there'll be a new version. So it'll be time to learn all over again.
great. Well, all right. Thank you for
That
showing
and
me
it kept
that.
asking me for like permission for you guys to see it, and I was like, I keep giving everybody permission, but I don't think it's working.
Yeah, I had sent a couple of requests, but nothing changed. So I wasn't sure what was going on.
Yeah, the YouTube is just the easiest way, and that's why I do it, just because sometimes things don't work the way we want them to.
Okay, perfect. Thank you.
Yep, no problem.
Does Alabama win this weekend?